Great. Okay, we're back. Let me get this so I can actually read it. Okay. So upstream approach. So this is that broken bridge that turned off our Zoom here. So upstream, think community impact strategies include the development of laws, policies, and regulation that help support the community in which it serves. When you think even farther upstream of that, what influences the development of laws, policies, and regulations? Elected officials. Voting is the ultimate upstream intervention when we are considering large scale and lasting approaches to public health. So just calling that out here, and I finished up with that towards the end as well. Midstream, that neighborhood impact, that's where those social determinants of health that I spoke to earlier in the presentation fall. So really evaluating resources available at the community and addressing and identifying the gaps that exist so that we can create meaningful interventions for those communities. And then individual impact, that's us pulling the people out of the river. That's when someone is presenting for direct medical care, clinical care services, and so defines medical interventions. So we'll look at this through 3 strategies that align with the considerations that I previously presented. First up is integrated healthcare. Integrated healthcare embraces a whole person approach and really aligns with that allostatic load theory, promotes collaboration, efficiency, and then incorporates social determinants of health into the same delivery system. Implicit bias training. So extending it, I think we're doing a good job of incorporating it at the academic level, but there's a lot of opportunity to expand within existing organizations. And then finally, data and research. So again, helping us clearly define and identify opportunities for improvement. So integrated healthcare, what is it? Why is it important? It considers physical and mental health at the same time and the direct impact that they have on each other. So we'll have behavioral health diagnoses that can impact physical health and vice versa. This slide just provides, again, a general overview, so not specific to maternal health just yet, but again, considering both of those systems at the same time when we're diagnosing an individual. It's patient-centered, and there's increased efficiency associated with it. So physical symptoms could be irritable bowel syndrome, palpitations, respiratory shortness of breath. While we need to work those up for a physical origin, it's also important to consider the role that anxiety might play, right? And so we could have someone that's presenting very much with an asthma attack, really evaluating them through that lens of physical health. If we don't find the root cause that way, extending out to our behavioral health partners and considering something like anxiety. PTSD, post-traumatic stress disorder, or depression are also included in that integrated model. And then extending it out to the perinatal, so pregnancy itself, and then the postpartum timeframes. It again aligns, the integrated healthcare model aligns with the allostatic load model, considers historical stressors by design, and incorporates social determinants of health risk factors into the development of the plan of care. Perinatal anxiety and depression, again, if you think back to where we started, individual risk factors, those are present, and again, something that is baked into the integrated care model. Social determinants of health, it's a central pillar of that integrated model, recognizes the impact to mental health so that those environmental stressors, socioeconomic stressors are considered at the same time. And then regular SDOH screening identifies any barriers to access. And so there are some proposals out on doing it not only on an annual basis, but with any major life change, so that you can really evaluate and have a consistent pulse on how that individual is faring in context to social determinants of health. Implicit bias training. And again, like I mentioned previously, I think we're doing a really great job in within the academic settings, especially within our medical school programs. But I think that there's opportunity to expand out to allied health professionals in our nursing program and other patient-facing clinical roles to make sure that that training happens in those academic programs as well. And that it's not a, this is month one, we're going to cover this, level set and set it and forget it. This is something that should be baked into regular check-ins, like the statistic that I provided earlier in the presentation on medical students, nearly half that were exposed to some sort of racist comment from a resident or attending physician. I think it's important to incorporate it ongoing into check-ins, especially as students start to get out into the clinical care settings, to make sure that they're in tune with implicit bias and how it can impact actions. And then bringing it to the bedside. So again, I think that we have some of our organizations, major systems are incorporating implicit bias, but there's absolutely room for improvement within the existing workforce. And so again, not only doing an annual training, but having continued training to existing workforce, especially in high acute areas like labor and delivery, emergency departments, so that people, again, are able to put their egos aside and identify and be comfortable in exploring why they might have a specific feeling when they're interacting with a certain population, a certain person. And again, making it something that it's okay to talk about and to recognize. That's the only way that we're going to really be able to address this head on. Finally, data and research. I'm a data nerd, and so really anyone that has that same background, garbage in, garbage out, right? You need to have a good data set to be able to have any sort of real analysis associated afterwards. And this is an example of where that has broken down for maternal health outcomes historically. So you can see this is describing something that referred to as the pregnancy box. And then it also cross-references ICD-10 codings, which is a diagnostic coding system. And starting the end of the 90s, beginning around 2000, we had the introduction of ICD-10 coding that directly linked a diagnosis to a pregnancy-related complication. Secondary to that, a lot of the information that we get at a statistic level when we're looking at maternal mortality and morbidity comes from vital records, and those are managed at the state level. And so the pregnancy box literally refers to the introduction of a checkbox on death certificates that would tie a diagnosis to pregnancy. And so an example of that would be, you could have a diagnosis of hemorrhage, but prior to that ICD-10 and the pregnancy box on a death record, it could just exist as independent as a hemorrhage and not tied to a maternal hemorrhage, something that occurred during childbirth. And so you can see that when both of those, the ICD-10 and then the staggered approach of the pregnancy checkbox was included across states, that our associated mortality rates started to increase. Now, does this mean that more people were falling into that category? Probably not. This is just, we're actually having a clear line of sight to what was happening for decades back, right? And so it's important to call that out. You can see, again, 4 states jumped up to 18 states several years later, up to 31 in about 2010, 42 in 2013, and it as of 2017 is when we had the pregnancy checkbox as a standard data point included in death records across all states. And every time I see this slide, it completely boggles my mind that it took that long to incorporate a checkbox, which is seemingly simple intervention to really be able to quantify a very important health outcome. Oops. Second to that is increased funding. So prioritizing data and research to promote maternal health outcomes requires funding. And this is an example, again, of an upstream intervention. So this supports the development of laws, regulations, policies, like we talked about in our upstream slide previously. And this is, again, driven by elected representatives. Examples of this, CMS has an annual priority framework that comes out. CMS is Centers for Medicare and Medicaid. This often will change and reflect the current presidential administration's goals, priorities when we're looking at health interventions. While this is predominantly setting the tone for Medicare and Medicaid, it also, we see that commercial payers follow suit when it comes to reimbursement and the associated quality metrics. So it really changes the landscape of the healthcare system overall. And then Medicaid waivers, we'll talk about on the next slide. And again, how those are often tied to the current presidential administration. You can see how this trends out over the 1990s to early 2000. We see a focus on broad coverage expansion, savings, and that was financed with savings from MCOs or managed care organizations. 2001 to 2010, there was a shift in focus to limiting some coverage expansion, but focusing again on cost sharing through different waiver programs. 2010 to 2017, we see the implementation of the ACA. So the first 4 years were pre-ACA expansion, building that foundation to allow for the regular match rate. And then 2014 to 2017, expansion of waivers. The DSRP describes a quality shift from quantity to quality. So reimbursing individual clinicians on health outcomes associated with patient panels that they serve. 2017 to 2020, see again that focus shifts back to limiting coverage, and specifically 2017 to 2020, we saw work requirements and other eligibility restrictions when we looked at Medicaid funding. There were some expansion in mental health services, so substance use disorder, seriously mental ill, and then SED or seriously emotionally disturbed individuals. There was expansion in those programs specifically, but on the whole, there were a lot of restrictions that were placed through Medicaid funding waivers. Current state, CMS response. So under the current administration, we have a framework for health equity that CMS is really promoting. Focus on data and promoting interoperability by standardization. So singing my love song here. Interoperability just really speaks to communication across acute and ambulatory settings, and standard data collection of race, ethnicity, SDOH, so social determinants of health. Having that standard approach to data collection allows us to have a high level overview of what's going on within the population, so we can avoid another pregnancy box situation by having access to important elements of the populations that we serve. So coming to the end of this presentation, want to bring back this statistic. I hope that you have, again, a little bit of optimism now when you see this, in that this highlights opportunity for improvement. We have control of the current conditions that impact our maternal mortality and morbidity rates in this country. We need to just clearly define those, and then have a consistent and standard approach to addressing and developing interventions. And then I'll close this wonderful quote from Dr. Martin Luther King Jr. "Of all the forms of inequality, injustice in health is the most shocking and inhumane." Thank you so much for your time and for rejoining after we dropped. I very much appreciate the platform and look forward to the conversation and Q&A. Thank you.
No, thank you very much, Andy. Thank you for the very thoughtful presentation. I'm sure we'll have a very robust dialogue coming up here. So I'm going to transition over to Dr. Terry Ann Scott, as well as to Dr. Ivana Thompson. Just to restate, Dr. Ivana Thompson is our local expert, associate professor of obstetrics and gynecology for the UW Medicine, and associate chair for justice equity, diversity, and inclusion.
Great. Thank you so much, Sean. And thank you, Ms. Romaine, for that at times disturbing and really eye-opening conversation. And I appreciate the fact that you also presented so many ways to dismantle those inequities. As I mentioned in the beginning, that's really what we seek to do with this lecture series, and you've done just that. So we really appreciate that. Thank you to all of you who have joined. I have an opening question, and then I'm going to turn it over to Dr. Thompson. So what can individuals do? Because I know a lot of the people on this call are healthcare providers, and many are not. What can you do to advocate for yourself or for pregnant women of color in their families?
And Dr. Scott, that question was for me or for Dr. Thompson? I'm sorry.
You.
Okay, thank you very much. As I mentioned, the ultimate upstream approach intervention is voting. That's something that's available to everyone, right? And being able to drive change comes with the support from our elected officials. There's a lot of guidance for patients to be an advocate and really have confidence in voicing concerns either prenatally or at the time of delivery. But quite frankly, I don't think that that's fair to the mothers in this nation or their support systems. We really, and we've seen in the example with Sarah Williams that doesn't always help, right? We still see poor outcomes associated. And so while I think it's important to empower individuals voting and having that implicit bias training and continuing the conversation on what's going on so that we can clearly define.
Awesome. I want to follow with like a statement and a question. And again, I'm really grateful for being here and to share the space with y'all. The first statement I wanted to make is just to say this is just I want to just acknowledge that women aren't the only people who are given birth. And I just want to acknowledge that we do have trans men, we do have other gender diverse individuals who are giving birth. And so the things that we're talking about in terms of women are things that we need to be thoughtful and inclusive about, including all birthing people. So I just want to put that out there for folks. And I see these really lovely comments from Heather and from Lauren, and I wanted to put together a question based on what they're seeing about reproductive justice and talking about midwifery. You spent in the last minute or so of the talk, you talked a lot about how we can like gather data and how data can inform the work that we're going to do to correct these injustices. And I wanted to ask you, how can we, as like people who work in healthcare, people who work in academics, how can we be mindful and inclusive about what data is valuable and what data are we capturing, and are we capturing data that's important to the people who are experiencing the harm?
Yeah, absolutely. It's a great question. And like you mentioned at the close, called out the current actions that CMS is proposing through that annual framework and really solidifying a standard approach to demographic collection. As simple as that sounds, there's so much variance within that, especially when we get into the granularity of ethnicity, right? Social determinants of health. There are multiple tools and screeners that we can use to assess and identify someone's risk associated with social determinant of health. And so I think that incorporating that into your clinical practice, specifically SDOH screening, is really helpful in ensuring that the organization that you work in collects what you might think are very basic demographic data points, but asking that follow-up question of what does that look like? Do we have a defined ethnicity set? Is it going to accurately describe and capture the population that we serve?
Ms. Romaine and Dr. Thompson, there's a question that's in the question and answer that I'll pose to both of you. So I love your answer when you were talking about the first question I asked, and how do people advocate for themselves? And you mentioned voting. Of course, that is near and dear to my heart with the work that we do at Common Power. And to go, oops, I think the question just is, oh, here we go. To continue with that, Joy asked a question: how do we convince state legislators about the role that they play and the importance of upstream interventions to prevent maternal mortality, especially in Black women? And I'll add to that, is there any work that either of your respective organizations are doing or plan to do to help kind of expose this information to legislators?
Dr. Thompson, do you want to start?
Sure. That's a really awesome question. And man, for me, when I hear that question, the heartstring that gets tugged, the thing that is salient to me, or that's ringing to me, is like, how do I make somebody else care? And that's really hard. And I think what we do to make state legislators care about the people that we take care of and our community members is we have to be like the mosquito in the ear. We have to be loud. We have to use our voices. We have to empower our community members to have voice, that they feel safe to have a voice with our legislators and to share their stories. I think a lot of times in interacting with legislators, and coming from academics and like working at an academic institution, I totally value data, and data is awesome in stats, but to convey the emotion that is behind like these disparities, like you need stories, you need patients to tell their stories, and we need to be continuous about people hearing us and making ourselves heard. And if folks aren't heard, or if your representative is not being responsive, then that's an impetus to get a new representative. That's what I can think of in the moment.
How about you,
Absolutely.
Ms. Remain?
Yeah, and to echo what Dr. Thompson just outlined, we, on the operations side of it, right, we prioritize things like patient advocacy groups and having that forum to allow, outside of the traditional patient satisfaction report that comes out, but really hold almost like a town hall forum for patients to voice what's working and what's not, so that we can leverage the good and then fix and address the bad, but through the voice of the patient. I think that's especially important when we're putting interventions into place at the healthcare operations level. And it doesn't just exist. The decision isn't made in a boardroom, right? And so you need to have that direct interaction with patients. And then again, like Dr. Thompson just outlined, like having the voices relayed to the representatives, and they need to hear what constituents are saying and what it is that we need.
You know, you opened the talk with a statistic that I wrote down: 80% of deaths are preventable. 80% are preventable. And then another one that Black women have 3 to 4 times the death rate. And those kinds of disturbing statistics, coupled with those personal stories, are so compelling. And when somebody says, what can we do? This conversation that we're having here, you presenting, those of you who are attending this and listening to this, those of you who will watch this and recording, that's the first step in what you can do, because now you are armed with that information. And so now you have a responsibility, all of us do, to be able to continue to expose this and tell folks and tell our legislators and make those calls. And I love that, Dr. Thompson, that mosquito in the ear. Absolutely. So I see Sean is asking a question: how do we best present the ROI that opening up clinics, access in underserved areas, such as South Seattle, is the right thing to do? And I think that that's a great question for both of you.
And this is just me thinking off the top of the dome, but thinking about return on investment, I would look at how opening up clinic availability decreases ED visits, or decreases like OB triage visits. If you can decrease the load on those departments, you're going to increase your profitability. Gosh, also, well, it's complicated, but you may also want to look at your statistics on keeping kids out the NICU. Even though NICUs are really big revenue generators for hospitals, which is kind of complex, but keeping kids out of the NICU seems like that would be a really great way to have cost savings. Yeah. If you can get more vaginal deliveries, you can have shorter postpartum stays. If you can implement programs to follow up on blood pressures outpatient, maybe you won't have so many preeclampsia readmits postpartum, like that kind of stuff. I'd have to think more on that.
Those are
Those
great.
are great. Yeah, those are great examples. And then the lagging indicator obviously is our mortality rates for the surrounding community. But yeah, getting in there and identifying, I think the ED utilization is probably going to be your fastest, metric when you're looking at return on investment, because you'll see that access open, not only for the ED, right? You're going to see the shared savings into that prenatal population as well.
Thank you. I know we're coming close to the end of our time. We're slightly over it, what we had put in the chat. But does anyone else have any other questions or comments that they would like to make?
I have a question.
Okay.
I think kind of echoing off what you said, Dr. Scott, about like what we can do now, you know, I mean, at any point, just especially with voting, you know, and us being with Common Power and the Institute, that's, you know, what I believe so strongly, what we all believe so strongly, and seeing these changes occur at that like legislative and, you know, federal level. But then also, I just think about like, you know, myself, my circle of friends, like as young Black women, like approaching this age where, you know, some we may start to have children and become pregnant and all these things, like conversations we should be having amongst, you know, within ourselves. And then also like, if that means, you know, finding providers and, you know, how do we approach that like time of our lives with, whether that be in conversation, you know, just amongst ourselves with providers and, you know, as we get to that point with our partners, whatever it may be, like these things that we should be noticing so that, you know, while we are experiencing that, maybe our families or our partners are looking out for XYZ, like those types of, you know, that kind of detailed and specific, but, you know, along with the voting, of course, that we all feel so strongly about. And that's for both of you and all of them.
I can start if you're okay with that, Dr. Thompson. I don't want to cut you off, but just thinking through, again, upstream approach to it, I would start the conversation now with your current OBGYN, because you should be having those annual well woman checks. And I think having the direct conversation of how do you consider race? Do you consider race a factor when you're looking at risk associated with pregnancy? It's a very straightforward question. And that initial response will tell you a lot.
Yeah, and share the names of the people where you go to get your healthcare, where you feel listened to, amongst your friends in that group. I, as a healthcare provider, I've seen a number of patients who get referred to me because they heard of me through somebody else. And people will bring up, especially my pregnant people, we'll talk about their concerns in relationship to race and being pregnant and what does that mean and what is their experience going to look like at my institution, and how do they, talking to them about how we can advocate for them to have a healthy and safe experience, one where they can feel empowered to voice what they're experiencing. So you need to find folks, which is sad, but you need to find the folks who will listen to you and kind of and take that and have those tough conversations with you, and we'll work to empower you.
Thank you both.
So I think we have one last question from Bessie Young. And I'll pose this to both of you. Can you discuss the role of doula programs to help decrease morbidity and mortality and why these are underutilized? So, and I think the follow-up question is, do the doula programs help decrease morbidity and mortality?
Yes, I want to go. Hey, Dr. Young, it's good. I'm glad that you're here. Yes. Doula programs do help to decrease morbidity and mortality. And for those who aren't aware, doulas are, I would describe them kind of as birth coaches. So they're not your healthcare provider, but they're kind of like your advocate, and they help pregnant and birthing people who are laboring. They help them to get through that process because it's work and it's hard. And I find that they can be really excellent supports and advocates in the room, especially for people who don't feel that they have that voice to advocate for themselves, which is nice. I feel that we don't utilize doulas because people don't know they exist. It's not covered by their health insurance plan, and they're expensive. Also, midwives. Yeah, people have been talking about midwives in the chat. I see y'all. Yes, midwives are excellent, and I really like working with my midwifery colleagues. And I think, I don't know, something that's been resonating with me for a while is I think that we need to be more inclusive about how we envision what a birthing experience can be. And I think that utilizing our midwife colleagues and about having different birthing spaces to accommodate people and their needs, I think can really work to help decrease this allostatic load that you were talking about, Angela. But you say your part. Sorry, I got really excited.
And also, no, this is great. And also,
Great.
Mr. Maid, once you answer that question, if you could also offer us any closing thoughts that you have after your incredible talk today.
Yeah, absolutely. Really, you said it best, Dr. Thompson. I completely, when I was pregnant, explored using a doula. But again, to the point that you made, I don't think that they're necessarily mainstream for a lot of people, and there's associated costs, which is unfortunate because they are associated with positive birth experience and positive health outcomes. And so huge proponent of using a doula. And yeah, it's unfortunate it's not quite mainstream, but I think that it should be. And closing comments. Again, want to focus on that 80% statistic. When I saw it in full transparency, my response was anger. It's just ridiculous to me that's the mortality rate that we see in our country today, that percentage is preventable. We could have done something for these women, for their families. And then also data. I think that, again, defining the problem, taking the ego out of it, embracing partners in the birthing experience. So doulas, midwives, OBGYNs working together with nurses and really listening to patients, their families, meeting them where they are and considering the whole person is going to get us where we need to be.
That's beautiful. Thank you. Thank you very much. Thank you for the conversation. Thank you for the work that you are doing. We really appreciate this. Thank you all who came right back on this conversation, and people put in the chat, this is too important. I don't want to miss the rest of this. So thank you all for doing that as well. Sean and I we will be letting you know very soon who is the next speaker in our diversity series. And Mr. Main, this was wonderful. This is exactly what our expectations and our vision was for this series. So thank you. And everyone, Dr. Thompson, thank you for joining us as well. We really appreciate it. Jordan, thanks. We would all have never been able to rejoin with this. And thank you for the work that you've done to push the Institute in this direction. Sean, did you have any closing comments?
No, I mean, thank you guys for bringing us this fabulous content. And again, thank you very much. And thank everyone out there in the audience for joining us for our quarterly lecture series. And as Dr. Scott said, stay tuned. Stay tuned for the next presentation. In the interim, we encourage you to continue to visit both of our websites, the Department of Medicine website, as well as the Institute for Common Power for brilliant ongoing content and additional resources. So till then, till we meet again, appreciate y'all.
Thanks, everyone. Have a great evening.